Hi, I'm Dr. Robin Cohen from the USC Keck School of Medicine in Los Angeles. I'm also the chair of the Workforce for Media Relations and Communication for the Society of Thoracic Surgeons. This is a recorded press briefing from research presented at the 57th annual meeting of the Society of Thoracic Surgeons. This presentation is entitled "The Impact of Residential Racial Segregation on Non-Small Cell Lung Cancer Treatment and Outcomes." It will be presented by Chandler Annesi from the Boston University School of Medicine in Massachusetts and discussed by Dr. Thomas Varghese from the University of Utah in Salt Lake City.
Today I'll be talking about the impact of residential racial segregation on non-small cell lung cancer treatment and outcomes. Non-small cell lung cancer accounts for 80 to 85% of lung cancer. If diagnosed early, 50 to 80% of patients are alive 5 years later. Black patients are less likely to be diagnosed with lung cancer and receive surgery for early stage cancer, but they are more likely to be diagnosed at a later stage. In previous studies, potential causes of these health disparities include socioeconomic status and genetics. Throughout history, Black Americans faced discrimination that segregated them into specific areas of a city, which was then solidified by the Homeowners Loan Corporation. This was a federally funded program which aimed to rescue the housing market at the time of the Great Depression. Areas of a city were categorized as best, still desirable, definitely declining, or hazardous, which linked to the supposed risks of investment in each area. Areas with Black residents were considered hazardous and did not qualify for government-backed loans for investment in the areas represented by the red and yellow areas on the red line map. This explicit devaluation of Black communities has had lasting effects, including intergenerational poverty, disparate education, low social mobility, and limited access to health care. Both of the maps on this slide represent Detroit. The one on the left is a demographic map from 2010, while the one on the right is a redline map from the 1930s. If you compare the two maps, you see a distinct overlap. Areas that have a large portion of Black residents on the demographic map align to those in red and yellow on the redline map, while areas with mostly white residents were assigned designations of best or still desirable. Areas of high residential segregation have been historically devalued to uphold inequities through redlining and the maintenance of racist policies. People living in areas of higher residential segregation are more likely to be of low socioeconomic status and have decreased social supports. Devaluation of these communities has decreased the likelihood of investment in the areas, leading to an increased burden of social and physical structures. There are fewer businesses open, which decreases the employment opportunities present. Fewer hospitals and clinics are open, decreasing the options for health care despite difficulties already present to receive care. The goal of our study was to assess the association of increased residential segregation due to racial discrimination and its effects on the healthcare disparities for Black patients with non-small cell lung cancer. Our population included Black and white patients from the National Cancer Institute's SEER database from 2004 to 2016. We examined residential segregation using the Index of Dissimilarity, which is measured on a scale from 0 to 1 based on the US Census. 0 represents full integration, while 1 represents full segregation. While the image on the slide represents the two extremes of IOD, real examples include Detroit with high residential segregation and an IOD of 0.87, while Salt Lake City has a relatively low residential segregation with an IOD of 0.48. The outcomes that we studied were advanced stage of diagnosis, which was considered stage 3 or 4, surgery for early stage disease, and cancer-specific survival at 5 years. We studied approximately 200,000 white and 35,000 Black patients. Black patients were more likely to present at advanced stage and less likely to receive surgery for early stage lung cancer, which is the standard of care at early stage. Differences in these disparities disappeared in areas with low segregation. Black patients in the highest levels of residential segregation have the worst survival, but mortality improved at lower levels of segregation. Ultimately, this figure shows that with increasing residential segregation, there is decreased survival for both Black and white patients. To address the racial disparities in lung cancer, policy reforms to reverse residential segregation and negative socioeconomic effects of discriminatory policies must be put in place. This includes reinvestment in minoritized and marginalized communities of high residential segregation and enacting reparative actions for the long history of discrimination. Thank you.
My name is Tom Varghese. I'm a general thoracic surgeon at the University of Utah, and I'm a health services researcher. I have the distinct honor and privilege of discussing the presentation that was just given at this year's annual meeting of the Society of Thoracic Surgeons, the impact of residential racial segregation on non-small cell lung cancer treatment and outcomes. This work comes from Boston University School of Medicine and the Boston Medical Center Department of Surgery, with first author, Ms. Chandler Annesi, who's a medical student, and doctors Poulson, Deckert, Lytle, and Suzuki. The aim of their presentation was to assess the association of increased residential segregation due to racial discrimination and its effect on the healthcare disparities for Black patients with non-small cell lung cancer. For the audience, it's important to remember a couple of different things. First, cancer is a reportable disease in the United States. Therefore, when any healthcare provider provides patients with care for their cancers, they're reported to report that to the state and regional cancer registries. Through the SEER program, the National Cancer Institute supports select population-based cancer registries in the United States to collect information about individuals with newly diagnosed cancer who reside within each of the registry's catchment areas. As of 2018, the SEER 21 was formed with the inclusion of Idaho, Massachusetts, and New York registries. Now, it's important to say that because with that recent expansion, now SEER is covering about 35% of the United States population, but for the current time period that this study was done, that was before that. That is, it's approximately 28% of the United States population. The other thing to remember for the audience is that the power of SEER. SEER is useful for looking at overall trends. Really, the reporting is on the outcomes with the first course therapy information. However, since medical records serve as the mainstay of information, the weaknesses of the SEER registry is that you don't have complete data on outpatient treatments, as well as you don't have any other further outcomes for second treatments or treatments for recurrent disease. Acknowledging all those limitations, though, SEER is still very powerful to look at overall trends. Now let's talk about the main outcome variable that they were looking at. And they were looking at a unique index called the index of dissimilarity. The index of dissimilarity has been present in segregation literature from the 1970s onwards. And it's a good metric to look at different communities. It is that how similar are they in terms of the degree of segregation. It's not a great metric to look at varying degrees or reasons for the segregation, in the sense that, let me give you an example. There's two ways that segregation can happen. There can be systemic segregation, where an external entity or government agency mandates that certain communities can only live in different populations. But the other way is random segregation. That is that as a minority myself, I may want to go and live in a specific area as compared to another area because there are more minorities there as well. This index doesn't do a good job of differentiating those two things. Acknowledging those limitations, though, this study is a very novel contribution to the literature. For too long, we've known, irrespective of the disease categories out there, minorities in general have worse outcomes. They have worse treatment outcomes, they have more morbidity, they have more mortality. The outcomes are just not the same. This particular study is an exploration into the why. Why is this occurring? And uniquely, the authors point out that where you live makes a huge difference in terms of your outcomes with cancer treatments. And we need to do something about it. I think that for the future, what we will need to do is go beyond these studies. we'd love to see future studies really looking at focused interventions in areas of underserved populations, opportunities where what are the specific interventions that you can do in these populations that eliminate the disparities. But this is an important contribution to the study, to the literature, because it's an opportunity of exploring those first steps and doing more in the years ahead. Thank you for the opportunity to discuss this paper.